evening, everyone. So we are joined tonight with Lisa from Great Ormond Street. Lisa is a specialist respiratory neuromuscular physiotherapist. I knew I'd get that mouthful wrong. She'd like to do a presentation on respiratory physiotherapy for SMA. So I shall pass you over to Lisa.
Evening, everyone. I hope you're all coping with the clock change and the hopefully soon to be end of lockdown. So today we're going to talk about respiratory physiotherapy for children with SMA. I've just got a few disclosures. So I'm on advisory panels for Roche and Novartis and the Neurology Academy, and I'm also a sub-investigator for Strive and Sprint. Today we're going to go through the science behind secretion clearance, the physiology of coughing and where it goes wrong in SMA, what type of chest physio can be done, a bit of research behind it, and some of the standards of care from 2018, and then the respiratory management of SMA1. What I'd quite like to point out at the moment, guys, is that this is entirely my practice and what I do. It is definitely not the only way, and people in various centres have different rules and different ideas behind chest physio, especially if you compare the UK to other countries. So let's have a little look at the science behind secretion clearance. So the main thing to think about is the acute and chronic respiratory disease. So in theory, SMA is not a chronic respiratory disease because it's not a problem with the lungs as such. However, as the phenotype of SMA is changing, there might be a chronic part to that if you think about long-term use of BiPAP and the retention of secretions that can create some more long-term problems. And if we think more about the acute problems that a lot of our patients face. So you can break it down into 3 stages. If we look at the increased mucus production to begin with. So human bronchial glands consist of mucus cells, serraceous cells, and water secretion. In healthy people, this produces a protective amount of mucus for the lower respiratory tract. However, what happens with hypersecretion is too much mucus is produced, and that then becomes pathological and no longer protective. This also causes a decrease in the mucociliary transport and an increase in mucus plugs. So that's the first problem. If you then move on to impaired mucociliary transport, so what is really key in this is your hydration state. And I'm not talking about how much you drink, I'm talking about the hydration state of your lungs. So in your lungs, you have something called an airway surface layer. And it's a fluid layer in your lungs, which is controlled by ion channels that regulate the mass of water and salt on the airway surface. Now, what happens is the airway surface layer is isotonic. So if there's more salt in the body, the water becomes depleted. So your cilia that sit in your airway surface layer then don't beat as effectively, and then that causes a problem with secretion clearance. Now, if you have more salt in the layer, water will flow passively into the layer, and the layer will increase, therefore becoming more fluid, and your cilia then sit in a nice airway surface layer and can then beat effectively. So it's really important that we keep the lungs hydrated. Now, the last one, which obviously is no surprise to anyone, is an impaired cough. So essentially, even if your secretions stay nice and loose, if you don't have the power or the ability to clear your secretions, then essentially it's like shaking a ketchup bottle, getting it all nice and loose, and then just leaving it there and never taking the lid off. So having an effective cough is really important. So why do we want to clear secretions from the lungs? So we already alluded to it at the beginning that if you leave secretions in your lungs, then that essentially can clog up your alveoli, your smallest part of your lungs, and reduce your gas exchange and cause plugging within your airways, which can then obviously cause a problem within different areas of your lungs. So we're really keen to make sure that those lungs stay nice and clear. And also, if you have retained secretions, that causes an increased risk for infections and inflammation of the lungs. So I always find this really fascinating because you're talking about different stages of a cough. So within a cough, you've actually got 4 stages. So the first one is airway irritation. So your brain recognizing that there's something there to cough. So that then triggers your body say, okay, I'll take a deep breath in. So that's your deep inspiration. You then get glottic closure and compression builds up in your lungs. And then as your glottis opens, you get expulsion, so expiratory muscle contraction and expulsion, which moves your secretions. Now, this little funny diagram up in the corner with the blue blob. So the blue blob is your secretions, and this is the actual mechanism that happens when you cough. So this little bit here, don't worry too much, but it's called your equal pressure point. So as you take a deep breath in and cough, that causes your equal pressure point to move, engulf the secretions, and then move them up towards the head. I always find it really fascinating. So let's have a think about where that goes wrong in SMA. So the first part is you have an abnormal inspiratory phase. So the inability to take an effective deep breath in. Some of our kids have impaired glottic or bulbar function, so you don't get that nice glottic closure to build that compression in the lungs. You get weak intercostals and abdominal muscles. Obviously, we know that the diaphragm is relatively well preserved in SMA, but you lose that ability to expel secretions, which all result in an impaired cough. So now for me, the question really is no longer whether we do physio or not for our kids with SMA, but more about what combination of physiotherapy treatments should we be doing. So this is just a nice little circle that I use to show what our options are. So we'll talk through each one on its own. So if we think about nebulizers and other medication. So the key here is you've got hypertonic saline, which is, for me, something we use a lot of. So with hypertonic saline, it disrupts the mucus gel of the secretions, so it reduces the viscosity and elasticity of your secretions. It also helps increase that airway surface layer that we were talking about earlier. So by putting salt or salty water into the airways, that then causes the water to travel into the airway surface layer and keeping it nice and hydrated. So the next one, which our pharmacist will kill me for talking about, is DNAs. So DNAs is something that isn't evidenced for children with SMA. The evidence very much comes from kids with cystic fibrosis, and it essentially works on the DNA of the sputum, so the actual makeup of the secretions, because of the high extracellular DNA in it. Now, it doesn't always work, and it's quite costly, but we have a few kids that if they've developed a respiratory infection, or they're struggling to wean back off their ventilator, or if they've got a really problematic secretion load with a high bacterial growth, sometimes we do use DNAs to help kind of progress them forward. It's not evidenced, but it definitely does work, and I know that there'll probably be a few people listening to this that will vouch for that. Now, with the changing phenotype, we are starting to see a change in using nebulized antibiotics in some of our children. So if you've had a repeated Pseudomonas growth, then one really common nebulizer that we might use is something called cholomycin. So quite often what clinicians will try and do is, if you have a first or even second Pseudomonas growth from a sputum sample, they'll try and treat it with oral antibiotics first. And if the oral antibiotics don't work, then they will try nebulized cholomycin. It tends to be about a 3-month trial, and it is effective in a lot of children, but the Pseudomonas growth really does need to be problematic to start you on a 3-month course, because you have to be quite careful around pregnant women. You have to be in a well-vented room. There are a few kind of side notes with using nebulized cholomycin. And then within this, we just thought we'd talk about nebulized salbutamol, which isn't something we tend to need in SMA, even though the standards of care mention it about if you're asthmatic. But it's more about, we use it if we need to give a patient hypertonic saline, but that in itself causes a bronchoconstriction, so a wheeze essentially. And what we'll do is, if we really need to use hypertonic saline, then we'll introduce a salbutamol nebulizer first and then give the hypertonic saline, because salbutamol is a bronchodilator, so it opens up the airways and relaxes the smooth muscle in the lungs. And then I couldn't really talk about medication without mentioning glycopyrronium and hyoscine. So glycopyrronium is an anticholinergic drug, so it helps reduce the amount of secretions. But what we really need to remember here is that it doesn't just act on salivary secretions, it acts on all secretions. And it has been shown to reduce gut motility. So it's not something that we put everyone on, but if drooling or excess secretions really are a problem, then it is something we'll think about. We prefer glyco to hyoscine, and the reason for that is glyco can be really well titrated and you can give much smaller doses, whereas hyoscine works on a patch, normally just behind the ear, and that patch normally takes, they say 3 days in, 3 days out, so it takes 3 days to build up to the correct dose and then 3 days to get out of the system once you remove the patch. Now, I am not a prescriber, but this is our practice at Great Ormond Street. But it is really important to note that every child is an individual and every child has their own amount of glyco or hyoscine, depending on what the clinician uses. So moving on to manual techniques. So in here, this encompasses percussion and what we call expiratory vibration. So the percussion is something we do with a cupped hand or a mask, depending, and it causes a vibration to travel through the chest wall, moving secretions away from the lining of the lungs and to a point where you can then encourage a child to cough or to use suction to clear them. It uses turbulent airflow in the lungs. Now, I do have a video of one of our patients who I do have permission, and if you can hear my voice in it, I'm really sorry. Okay. So it's quite a firm pat, and if you do it too lightly, then it's not effective, but it is very well tolerated by most children, and it's a nice treatment when secretions aren't a huge problem, or you might just be starting off with physio and it's kind of getting you into the program. So the next one we'll talk about is a manual assisted cough. Now, unfortunately, I don't have a video of this, but what this is essentially using another person to replace what the abdominal muscles can't do. So it helps with that expulsion phase. So it's a in and upward scooping mechanism over the abdomen, and really important with all physio that you've not fed or eaten before, because you don't want to cause any vomiting. Now, in the picture, you can see they're using 2 hands, but actually I prefer using either my forearm or one hand, because you want to make sure that when you do it, it's nice and even and one hand doesn't go first, because that can make the person feel quite sick. But essentially, it's using that upward scooping mechanism to increase that expulsion to improve your peak cough flow. So the next one we'll move on to is breath stacking or lung volume recruitment bags. So you can see here that these are lung volume recruitment bags, so different attachments, but you essentially have a face mask, mouthpiece, or tracheostomy interface, depending. A one-way valve here, just by where that yellow label is, and then this is a self-inflating bag. So what I've actually got a video of one of our patients. Now, this patient doesn't have SMA, but does use this really effectively, so it's a nice video. So let's show you that. So you can see in the video that he does 3 breaths in, so 1, 2, 3, and that he's gradually expanding his lungs by each breath. So it's a breath in on top of a breath in on top of a breath in, hence the term breath stacking. So you're putting one on top of the other, which then uses the natural elastic recoil in your lungs to then get a better cough. So we'll move on to the vest and interpercussive pulmonary ventilation. So this is something called a metaneb. This is a percussion air, which is, as you can probably tell by the photo, pretty old now. And then this is a vest. So these techniques, especially the percussion air and IPPV, are far more common in other countries. It's not something that is common practice in the UK, Belgium and France use it much more than we do, and it's something they tend to use in an acute situation. So it's not something that would be given to someone at home, but more if you came into hospital acutely unwell. So what it does is it gives high frequency positive end expiratory pressure, so a vibration really, really fast, far quicker than you could do by hand. And what it does is it builds the vibration to move secretions away from the chest wall and therefore clearing them. So it favors proximal secretion mobilization. Now, the vest is something that is obviously more available in this country and more available for home use. It's not something that is commonly used in SMA. And the reason behind that really is if you think about the mechanism of it, it's a really fast vibration, much like the percussion air or the Metanev, but it's an external force rather than an internal force. So with this, I'll show you a video in a minute, but the really high vibrations causes shearing forces to move the secretions away from the lungs. Now, if we think about that catch-up bottle that we used at the beginning for the analogy, so it's like shaking a catch-up bottle really, really quickly. But with SMA, because the cough is so ineffective in some patients, if you just shake it all around and then you leave it down there, it's again like shaking that catch-up bottle and never taking the lid off. So it's really important that if you were to use a vest, that is then paired with something that then helps you cough better. So I've got a little video here. Some of you. So you can see the really high frequency vibrations, and that helps move secretions. Now, in the patients I use this with who have SMA, I would always make sure they were on their non-invasive ventilator, because you want to make sure that you're not going to de-recruit or lose any lung volume while you do this, because it does inflate and cause compression around the chest wall. So you really need to make sure you're doing it with someone who knows what they're doing. Great. So now the one that everyone talks about, the cough assist. So there are actually lots of different types. So the first picture is the old Philips Emerson, which hopefully no one tends to use anymore because it's quite outdated now. This is the Philips E70, and then you have the Nippy Clearway 1 and the Nippy Clearway 2. So the Nippy Clearway 2 has only come out very recently, and we are starting to use this one at Great Ormond Street, and some of our patients have moved on to this or been given this because it's just come out. So I've got a little video to show the use. This is the original one. So you can see expiratory vibrations with this as well. So the expiratory vibrations are a scooping up mechanism. So again, it's increasing that expiratory flow and then adding on the shape to help with those shearing forces as well. So you can see that really well tolerated, and the chest wall expands really nicely, and it gives a nice effective cough as well. So indications for cough assist. So obviously the standards of care for SMA1 say that most kids should have one. I think out of our cohort, gosh, I think I've got one, maybe two patients that don't have one, and that's just because they're really strong and just don't need it. But generally speaking, the indications are recurrent chest infections with a prolonged recovery, a weak cough, and that can be judged clinically, or multiple courses of antibiotics for infections, multiple hospital admissions for chest infections, and there obviously is a huge preventative feature by using a cough assist. So looking at some of the research, so this I think demonstrates it really nicely. So if you look down here, this is peak cough flow and FVC, so forced vital capacity. And the lower down you are in this, the more that you need all the help you can get, essentially. So if you're in this red area down here, then you really should be thinking about using a cough assist, and sometimes with a manual technique over the top. So whether that be an expiratory vibration or a manual assisted cough, they would both work well. Then lower down here, then you've got assisted insufflation. So that could be like using the LVR bag or breast stacking. and combining that with a manual assisted cough, or here just using the LVR bag, and the AS stands for air stacking, or breath stacking as we call it. And then obviously if you're a bit stronger here, then you could use a manual assisted cough alone. Now here, GPD is glossopharyngeal breathing, which is called frog breathing. It's something that tends to be something that is used in spinal cord injuries, and it's essentially swallowing air into your lungs on purpose to then get a better cough. But it's a very hard technique to learn and not something I would ever use in pediatrics. But it is something that is used in older spinal cord injuries. Having a little look at the research. So luckily for me, they say the role of a respiratory physiotherapist is really important. So I keep my job. And if we look at there is an agreement for cough assist being vital in SMA1. There's absolutely no consensus regarding pressures, and people range from 10 to 50 for the insufflation breath, all the way to -10 to -60 on exsufflation. And I know that the states have very fixed ideas about what they should use. In younger patients, they say that you should have a longer breath in than the breath out, but that again, there's a lot of variation in this, and age is a huge factor in this. Looking at high frequency chest wall oscillation, so that's the best. There's no evidence behind it, but again, should be used in conjunction with ventilation. And like I said earlier, you still have to use other techniques to make sure you're clearing the secretions. And as we all do, airway clearance should be intensified in acute illness. So then a little bit more research. So they say that cough assist is effective for patients with a peak cough flow of lower than 160 litres per minute. Now, obviously, the younger the patient, you can't really get them to do peak cough flow tests because that doesn't work. So we would assess them clinically for that. And then if we think about the fact that higher pressures might be clinically required for weaker patients, and again, wide variation in settings that are prescribed for patients. Some people start low and increase to get an improved cough, but again, it depends on your experience as a clinician as well. So they say that your TI should be at least 1 second or more to make sure you're recruiting alveoli, so the smallest part of your lungs. But again, if you've got a really small patient, and we've started cough assist on patients that are sort of 8 weeks old, then the TI of 1 just isn't feasible with a really high respiratory rate. So you just need to be a bit cautious of that. And not much changes with your secretion clearance when you increase the TE, so the length of time for your cough. But some patients will do a quick, short, sharp cough, and some patients will need a repeated cough to be able to clear their secretions. So that's really how we judge setting the TE. Really important one is making sure that you have periods of rest in between area clearance techniques to prevent muscle fatigue. So I tend to say morning and evening chest physio, and then if you're unwell, go up to sort of 4 times a day, and make sure you've got a really good rest in between those sets with time back on ventilation if you have ventilation. Now, this is really contentious for me because I don't do this and I don't believe you should, but the evidence suggests that you should end on an insufflation, so end on a breath in. Now, for me, in patients with bulbar weakness and an inability to maintain their secretions in their oropharynx, so in the top part of their mouth, if you work really hard to get their secretions out and then you blast them with a huge breath in, at the end of that, the secretions are just going to go back down. So all that hard work you and your child have gone through to clear your secretions, you then push some of them back down. Not all of them, but some of them. So for me, I would far rather end on a cough, quickly do a suction, clear any secretions that are there, and then go back on your ventilator. If you need to, then end on a insufflation. But again, that's my practice and personal preference. And we're looking at talking a bit about extubation. So if you were on an intensive care and did require intubation, then the evidence for using a cough assist on an endotracheal tube, so on an intubated patient, is safe and effective, and it does really help prevent re-intubation. So you could use it in an intensive care setting if unfortunately your child was intubated, and then once they'd been successfully extubated, you could then use it via the mask straight away. and there is a lot of evidence that says it prevents reintubation. Obviously, you need to be really careful around muscle fatigue at that point. And I can't advocate enough that individualized programs are really important with all of these kids with SMA. No two children are the same, and everyone does require something very slightly different, but it does make a big difference to each child. So just having a little look at the standards of care from 2018. Now, I'm just going to say now that there are parts of this that I actually don't agree with. There was no respiratory physiotherapist on the panel for this. There was pulmonologists and respiratory consultants, but no physio. So I'm just going to put that out there now. So looking at assessment, so they say that you should monitor SATs and carbon dioxide, and that a sleep study should be used to confirm sleep disordered breathing or respiratory failure, that you should be assessed for reflux, and clinic visits should be 3 to 6 monthly, but ideally 3 monthly. Now, firstly, some of our kids who have SMA1 or are non-sitters have a completely normal sleep study, but actually I'll show you in a little bit some of the criteria that we use at Great Ormond Street to decide whether someone should or shouldn't be on non-invasive ventilation. So if we think about intervention, so they say a proactive approach, that respiratory physio should initiate and support airway clearance. Then they talk about respiratory range of motion, which I'm not entirely sure what they mean by that. I assume it means deep breaths in, so making sure that you expand your lungs, but they don't clarify. Then looking at airway clearance, so manual chest physiotherapy plus a cough assist should be proactive. It should be on a clinical assessment of a cough or a peak cough load, depending, aiming for pressures somewhere between +30 to -40. But again, some patients don't need that much. Some patients really do. Looking at the fact that you have no airway obstruction or lung disease. So they said there's a minimal risk of pneumothorax, but with the changing phenotype, we're actually seeing that some kids do grow a lot more bacteria than we would expect them to. So whether that is a factor when we're looking at secretion management, the jury's still out. They talk about gastric venting, if possible, to prevent gastric distension. So some kids, when they're on non-invasive ventilation or cough assist, some of the air might go down the tummy. So if you've got a gastrostomy or an NG tube, then by venting their stomachs, that might help. Making sure that you've got a suction unit. And they say no high frequency chest wall oscillation for ineffective cough or secretion clearance. Now, for me, that shouldn't be a no, it should be a consideration, and it should have a side note or caveat to say it should be paired with something else, so with something that helps you cough. So then if we move on to ventilation, so they say it should be used in all symptomatic infants prior to respiratory failure, and they say it can prevent or minimize chest wall distortion. That's very dubious. There's been a couple of papers that show it might be able to help, but the papers that have been written about that choose their children very specifically about who they present for that fact. It should be used to palliate dyspnea, so to prevent shortness of breath, not to use CPAP. The interface is vital, so making sure that whatever mask you're using fits really well. And in non-sitters, we're really looking to correct gas exchange and decrease work of breathing. Now, the use of tracheostomy is very contentious in the UK, and it's very much on an individual child basis and for that specific child. It's not common practice, and the hope with all the treatments that are emerging is that that will become less and less of a topic, although I do know of one child that has been tracheostomized with SMA1. Then looking at medications, so they say not to use hypertonic saline or Dornase chronically, as there's no evidence for it. Glycopyrrolate should be used with caution. There's no decision regarding Botox for the salivary gland, and that everyone should get their RSV vaccine if they're eligible. So if we have a quick look at sitters, so again, it should be a physical examination with a clinical assessment of a cough, spirometry if available, and if the child is able to do that. They should have sleep studies, be assessed for reflux, and be reviewed every 6 months in clinic. Looking at airway clearance, they say manual chest physiotherapy with a cough assist if indicated, proactive, making sure we're assessing clinically or using a peak cough flow, and the settings for a cough assist or mechanical insufflation exhalation are similar to that in the non-sitters. Looking at ventilation, it should be used in all symptomatic patients. Again, individualized care for their needs and quality of life. They should have a sleep study to determine sleep disorder breathing or respiratory failure, and again, making sure they use BiPAP and not CPAP. Looking at medication, they talk about nebulized bronchodilators if you're asthmatic. Now, for me, that should be on a whole nother pathway. And if you need bronchodilators in your SMA1, that's more because you're using hypertonic saline and you need the bronchodilator. Again, they say that you shouldn't use nebulized mucolytics chronically, and you should have your annual flu and pneumococcal immunizations. Now, walkers, there's far less, so it should be a physical exam, clinical assessment of a cough, an assessment for symptoms of sleep apnea or hypoventilation. If you are concerned, then you would have spirometry sleep studies, but you would be assessed very carefully for any pre-ops. And then intervention, they say you don't need any proactive interventions and should be supportive care and making sure you're up to date with all your immunizations. So there's one part of the standards of care that looks at acute care management. So it says that individuals with SMA are very vulnerable to respiratory decompensation related to infections, aspirations, and impaired secretion clearance. You're looking at baseline muscle weakness is often exacerbated during illness. Now, I know from seeing some of our kids that unfortunately have got to PICU that when they are in that acute phase, that their muscle function is definitely not as good as I know it to be. So let's have a little look at the things they talk about. So what do we need to do? So we need to avoid fasting. So we avoid going into that metabolic acidosis, making sure that our kids are on appropriate nutritional support, making sure we've got anticipatory care plans, making sure we escalate care appropriately. So for example, if you did go into a local and all they had there was Optiflow or CPAP with some oxygen, then that would be okay to hold on, but then you would need to be retrieved and taken to a tertiary centre where you would be able to receive BiPAP or, if needed, to be intubated. And that is really important. If that's all you have, then that's better than nothing, but it's really important to make sure you're then retrieved to a centre that can look after you properly. Making sure that you've got appropriate antibiotics. We know who the emergency contacts are, so not only parents, but also the wider team. So for example, if any of our patients from Great Ormond Street ended up in a local, making sure that team know who to contact. Making sure that our kids stay adequately hydrated. Really, multidisciplinary team working with the family is so vital. I can't stress that enough. Making sure that we've got the right airway clearance techniques in place and making sure that the ventilator parameters are appropriate for those kids. And those two are really key for, like, respiratory management is really important, especially in acute care. Now, just talking a little bit more about NIV and SMA1. So this is our criteria that we use at Great Ormond Street. So you can see that we've got main criteria and supportive criteria. So you would need to have one of the main criteria plus or minus some of the supportive criteria. So any of those four would trigger the team to start thinking about non-invasive ventilation. And again, all of our kids would go on to BiPAP and not CPAP. So this is something that we've created at Great Ormond Street. It's just been published. So it's called the GSR scoring system. So the Great Ormond Street scoring system for children with SMA1. And it looks at kids that have gone on to treatment and tracking their respiratory status to give us a better idea of how stable they are with the support that we're giving. So every time that we see a patient, we will score them on our scoring system, And then down at the bottom, you can see the interpretation. So the lower the score, the more stable the respiratory status is with less support. And we use this to track how well kids are doing once they've started treatment. Now, over here, you can see this is the pathway that we use at Great Ormond Street. So for me to see kids, so I'd have a referral either from the neuromuscular team or the respiratory team, and then each kid would be set up with their own individual management plan, and that plan would really be ongoing, whether that be positioning, manual techniques, suctioning, nebulizers, cough assist, whatever that may be. We then always make sure we put a referral into community care. That doesn't always go smoothly because for things like suction catheters and suction machines, that all comes through community teams for us. And then all of my kids are followed up in the outpatient clinic, and especially at the moment with telephone or even Zoom support. So this is what I call the typical management of an SMA1 kid at Great Ormond Street. So you can see that they start on some physiotherapy techniques, but within that, we're going to do non-invasive ventilation and sleep studies, adding in some nebulizers as and when they need it, and again, adding in prophylactic and oral antibiotics through the winter months if they need it. And some of our kids are even on prophylactic antibiotics all year round, and then making sure that we're reviewing them regularly in an outpatient clinic. Depends on the patient. So the standards of care say 3 monthly. And definitely when I'm first starting out with some kids, I might even see them weekly at the beginning. But then as they become more stable on their management and parents are more confident, then that might go to 3 or even 4 to 6 monthly, depending. And again, making sure that that MDT management really feeds in there. And that's it. Any questions?
Yeah, I do. We have quite a few questions actually coming through. Hold tight.
Oh, there's lots of scrolling going on there, Kelly.
Just trying to find out what the top one was. Right, okay, here we go. We get quite a lot of people who watch from abroad as well, Lisa. So some of the questions may or may not be relevant, but okay, so what kind of treatment can be given to a patient whilst they have a ventilator and a tube? So I'm guessing they mean intubated.
When you're intubated. So every centre treats slightly differently. If it was one of our kids that was ventilated, then there's a technique called bagging, and it's with a little green bag, depending on the child, depends on the size of the bag. And you would you take them off the mechanical ventilator and you put them on the green bag and you would hand ventilate them. And then by doing different techniques on the bag, you can mobilize secretions, and you add in like expiratory vibrations and things like that to help mobilize secretions. Like I said, though, there's a lot of evidence that says using a cough assist on an endotracheal tube is really effective. And sometimes we use neat saline, 0.9 saline down the endotracheal tubes to help mobilize secretions. Also, we use nebulizers. I mean, there's a whole range of different things. There's also a lot of evidence now for early mobility, even when you've got an endotracheal tube in. And we've got a new program that's just started at Great Ormond Street called Gosh Go. And it's looking at, as long as the endotracheal tube is safe, mobilizing the patient as appropriate. So, for example, getting them out from their chair or sitting out on a parent's lap, because we know that movement not only helps with lung movement and secretion movement, but also preventing muscle atrophy.
Okay. Next question. I have BiPAP, but since starting treatment, I feel my breathing is deeper and my levels are not, so the pressures are not right. Is there a way to know what settings you need, or is this trial and error?
So you really need to be having a sleep study for that, because your sleep study should have oxygenation and carbon dioxide monitoring. So we have very specific requirements for carbon dioxide levels and SATs. So we would want to make sure that your ventilator was titrated appropriately for you. So what I would recommend for that person is to contact their centre, whoever gave them the BiPAP, or ping me an email and I can try and help as well. and just make sure that they're getting the right type of sleep study to make sure that their ventilator's titrated well.
What should I do when my son is in well and he has just eaten but then needs to cough? Should we clear the chest or should we wait?
I think it depends on how they're fed and how poorly they are and if they're prone to vomiting. So if there's an NG tube and they've just had a massive milk feed, then I'd probably take the feed out and do the chest physio. If they're orally fed, there's not really much you can do. If they really need to cough and that is their biggest risk, then I would wait as long as is safe, but then I would crack on and get some chest physio done. You just need to be really careful of vomiting and then aspiration. That's the main reason we say to wait so long.
I have no idea what this next question is. I'm hoping you will.
I'll try.
Okay. Is the free Aspire useful?
Free Aspire?
Yeah. I don't know what it is.
No, I can't say I do either.
Okay.
Not something I've heard of.
No, I haven't.
Free Aspire.
Yeah. Are you Googling?
I am Googling. I'm intrigued. It's a new device for the management of airway clearance.
Oh.
I mean, I've never heard of that. It looks like it's come out of Italy by the people that have written the paper on it.
Okay.
I really couldn't comment. I could look it up, but pass on that one. Sorry.
Yeah. Okay, so this next one. Okay. In adults with SMA who require breathing assistance overnight, is BiPAP always preferred over CPAP, or is this a case-by-case basis? And there's a second part to that, but I'll let you answer that bit first.
So it depends on the reason you're getting your ventilator. So if it is not a muscle weakness and it's purely obstructive sleep apnea, then there could be an argument for CPAP. But generally speaking, with neuromuscular disease, it should always be BiPAP, but it depends on the sleep study for that particular patient. But generally speaking, it should be BiPAP.
Okay, and the second part to their question is, and once someone begins to use a BiPAP or a CPAP overnight, will this generally result in a decrease in lung function, strength and volume due to using the breathing muscles less?
No, it shouldn't do, because when we go to sleep, we all relax our muscles anyway. So it shouldn't make any difference during the day. It's just something that when you go to sleep, your muscles relax anyway. And if you have an underlying neuromuscular condition, they relax even more. So you then can't clear your carbon dioxide. So it shouldn't impact.
I see so many cases of people who are being refused BiPAP because the doctors told them once your child has BiPAP, they will become dependent on it and they'll never breathe independently again.
That's just not true.
I know. I've had a child who's been BiPAP dependent and now through treatment isn't, but he's no weaker.
If anything, by ventilating effectively at night,
makes
you
them
then
stronger.
improve them during the day.
Yeah, 100% agree. Right. Someone's asked, did you show breathing exercises or did they miss it?
No, I didn't show breathing exercises because we don't tend to use them. You have to follow quite careful instructions for breathing exercises, and most of my kids don't tend to follow instructions. It tends to be something for older. So the breathing exercises that are done more in adults is something called the active cycle of breathing, where you would use deep breaths followed by huffs and then followed by coughs to help mobilize secretions. There is also for older people using something called bubble pep, but these are all very much effort dependent. So bubble pep is where you have a bottle and you fill it to a very specific level with water, and then you essentially put like a giant straw into it and you blow against the resistance of the water and you create bubbles. So by blowing against the resistance in the water, you create positive end expiratory pressure, so you splint your lungs open, and by the bubbles cause that vibration in the lungs. But it's very effort dependent, so it depends on the child or adult, and depends how much they can put in, depends on how much they can get out of it.
Okay. So there's two parts to this next question as well. So it says, hi Lisa, thank you for this. I have SMA type 2, I'm 35, and also have a lung disease called LMA. With positive pressure, I'm at risk of, I can never say it, you know, where it blows holes.
Pneumothorax?
Yeah, I always call it a pneumothermin. I have names for everything.
Definitely not a pneumothermin, but okay.
It's a pneumothermin, yeah. For people who can't use cough assist, CPAP or BiPAP, but might fall into the red zone for not moving secretions, what do you recommend for preventative exercises, and how often and how long for? But she's also said, in addition, I'm on 1.5 litres of oxygen up to 16 hours due to low sats of 70 during the night because of the LMA affecting the alveoli.
Can you just read that again? Because it's quite a long question. Sorry. I just want to make sure I answer it.
Okay. So she has SMA type 2 and she's 35. She has a lung disease called LMA. With positive pressure, she's at a risk of pneumothermin. For people who can't use cough assist, CPAP or BiPAP, but might fall into the red zone for not moving secretions, what do you recommend for preventative exercises? She's also on 1.5 litres because she can't maintain her sats at night because of the LMA.
Okay, so firstly, I am very much a paediatric physio, but I can try and answer this question as best I can. So the fact that you can't use positive pressure obviously puts you at risk of retaining secretions. You're talking about going back to kind of what we used to do before these devices came out. So looking at things like postural drainage, percussion, manual assisted coughs, things like that. Now, the one thing you could do is speak to your respiratory physician and ask if how much can you not use positive pressure? Is it a case that you could do something like bubble pep with less water, therefore less PEEP, so it's a small amount of PEEP, and that might help with the oscillations. Or you could look at something like a vest, because obviously that's an external pressure rather than an internal pressure. That might help you clear secretions, and then combine that with something like a manual assisted cough to help get the secretions out. Would probably be my best ideas. You could look at using some mucolytic nebulizers to help loosen the secretions, so when you do have them, they are easier to clear.
Okay.
I hope that answers it.
Yeah, I think so. Hold on. Right. Please, can you tell us the setting you use on the E70 for an SMA patient of 10 months old, 7 kg in weight?
Oh, that's very specific. Firstly, I don't tend to use the E70. I'm much more of a Clearway fan myself, especially the Clearway 2. But the settings would be the... Say again, Kelly?
Said I was jealous. I want the Clearway 2.
Oh, sorry. You need to switch to Gosh. So that's really specific. And it doesn't just depend on the weight or the age of the child. It's more about chest wall compliance and chest wall shape as well. It would depend if you were on BiPAP already, because if you were already on BiPAP, then that would give your clinician a starting point to then move up from. I've got kids that are 4 months that are on higher pressures than some of my kids are 3 years old. I'm really reluctant to give a number. I'm very happy if that person wants to email me directly with a bit more information, and then I could be a bit more specific. But people who put numbers on cough assist without seeing the patient, I'm always a bit dubious about. But I'm all very much individual patient focused. So I'm very happy to help, but I need more information.
Okay. Should you do respiratory exercises daily to help lung strength and volume, or just when unwell?
So I tend to prescribe prophylactic chest physiotherapy. So that would be something you would do every day, 1 to twice a day, depending on the patient, to keep you well. There is a huge role in preventative chest clearance and keeping these kids well and out of hospital. So I'm very much in the prophylactic preventative corner.
Okay, I just need to go into my notes because I had some forwarded to me earlier as well.
Just to add to that, Kelly, just if you did become unwell, then that prophylactic treatment should be intensified. And occasionally, especially on the new offices, you can set well and unwell settings. So you can have more than one program. So
you can see how much actually they're getting as well, can't you?
Yeah, it gives an estimate. It's very much estimated, and the company do stress that it's an estimated inspiratory tidal volume and an estimated peak cough flow.
I love a new tool. Right, okay.
See how I feel. I'm like a kid in a sweet shop.
I love it. I've already been onto the team like 2 weeks ago. I'm like, please send me one. I need one. I've seen kids with it now. Right, okay. Sorry, 2 seconds. So my son, 5 years old, has SMA type 1. He was diagnosed when he was 3 months old, and he had Spinraza since he was 10 months. He is tracked and ventilator dependent. He had his physio sessions without the ventilator. When it comes to respiratory issues, his main problem is the secretions. Because of that, taking him off his vent can be quite difficult because he needs suctioning quite often. Is there anything we can do to minimise the secretions? They're in Greece, you see, so...
Say again?
They're in Greece.
Okay, so it depends on what chest physio they're doing. Did she say in the message? No.
No, she said he has his physio sessions without the ventilator.
So it would depend on what type of physio they're doing. If the secretions are a real problem, then it depends on whether they're too thick or too loose, because obviously you do different things for...
Yeah.
If they're copious but really loose, then I would suggest maybe trying some glyco or hyoscine, but with caution. Quite often what we do is if a patient has loads of oral secretions but their chest is still quite a problem, what we'll do is combine a hyoscine or glycopyrrolate, more often glycopyrrolate, with a hypertonic saline nebulizer. So we're drying up what's up here, but making sure the chest stays nice and clear and loose. It's quite common doing that.
All right. We've already answered this one. Can you confirm that using BiPAP at night does not make you dependent or weaken your respiratory? Well, we've already confirmed that you don't believe that as well. So here, next one. I assume those that have started treatment should not have their respiratory care tampered with or changed based solely on the fact that they are on treatment.
No, I mean, once you've started treatment, you should be closely monitored.
Yeah.
You should be followed up regularly. So your management should be titrated as a result of that. And that's actually something we've seen using our new scoring system, is that whereas some people are quite reluctant to down titrate because everyone's always very much, you must do this, you must do that, because everyone's so worried about secretions. Actually, some of our kids with treatment have improved, and we've seen that reflected in their scoring system as well.
Yeah, Vinny's come down on pressures since treatment.
It's not just about pressures though, it's about how often and how dependent you are on cough assist. You might have had to use nebulizers and now you don't have to use nebulizers. You might move from being over 16 hours ventilated to then just nocturnal and naps, or even just when you're unwell. Like it's some of the kids that we look after have changed massively after treatment. It's quite incredible.
Yeah, it's nice to see, isn't it?
Really nice to see. I love getting my videos and stuff from all my kids.
Yeah. So someone's asked about drainage and positioning when lifting secretions.
Okay.
Talking about general drainage.
So it's postural drainage. So for example, if you wanted to drain an upper lobe, so the tops of your lungs, then either lying down with a head elevated or in sitting, that actually, this is in kids, that actually drains your upper lobes most effectively is in sitting. Side lying flat would be predominantly for your middle lobes. And they used to recommend head down for lower lobes, but we really don't recommend that anymore. So side lying.
That's
Yeah, just side lying.
He's always down.
I mean, in kids, we don't see the lower lobes as being as much of a problem as the upper lobes tend to, because in kids you preferentially ventilate your upper lobes, and then as you get older you ventilate more of your lungs.
In case of another rise in cases, I'm guessing this is COVID, is there better services put in place to access masks that don't release air? Some people were delayed using equipment.
This is related to the non-vented masks.
Yeah.
So I can only say what we did in COVID, because that's the practice that we believe in. So we actually kept our kids on their vented masks, and we made sure they were isolated in a cubicle that was negative pressure. Some people switched to non-vented masks, but then to be able to do that, you have to make sure you've got an expiratory valve somewhere, otherwise your CO2 is going to go through the roof. So it depends on the ventilator. If it's a ventilator that can do dual limbed, then, so what I mean by that is you have one limb for the breath in and then another limb for the breath out, then you can use a non-vented mask because you're not at risk of retaining CO2. But we actually kept all our kids, even when they were admitted, on their usual masks.
Okay. How common is sleep apnea in SMA children?
I couldn't give you a stat on it. It doesn't tend to be obstructive sleep apnea that we see in these kids. It tends to be more hypoventilation.
Okay. If my daughter with SMA is taken ill but is not tube fed, do I need to worry about fasting?
So if your child was really unwell, then I would probably make sure that while she was unwell, that she had a way of being fed that didn't require oral feeding. You need to make sure you're getting adequate fluid and nutrition in. So whether that be an NG tube or an alternative, then I would suggest that. But the fasting is really important to prevent that acidosis we spoke about. So it depends on how long you're talking about. If you were unwell for quite a time and you didn't want to eat or drink, that could be a real problem for someone with SMA. So you do need to make sure you look at an alternative method of feeding.
Okay. 2 seconds, I lost my bloody page. To Joseph, who thanked Lisa for the answer and wanted to know how to contact her. If you message TreatSMA's page, we will pass on Lisa's email, if that's all right with you.
I've got my, if I go back to my first screen, I've got my email address.
Okay, so Lisa will put up her email address, so if anyone's got any queries, they can contact Lisa personally. I'm an adult with type 2 and I get lots of chest infections and tilt head down whilst doing chest physio. Should I stop doing this?
I mean, the issue with head down is reflux, so and vomiting. So if you're an adult and you're not at risk of refluxing, and that is the way you have cleared your secretions and it's fine for you, then I wouldn't change your practice. It's just not something we tend to recommend anymore.
I think that is it, actually, for questions. Let me just see what Marnie says, because she's my question lady. She's typing.
I feel like we should put some hold music on just to occupy everyone.
And Vinny's just been singing. I'm surprised you haven't heard him. Right, that is it, Lisa.
Great.
That is all the questions. So I think if anyone has any more questions, then they can contact us and then we can obviously put them in touch.
Yeah, I'm happy if you want to email me at my Grey Ormond Street account. That's not a problem at all. And that person who had those specific questions about the cough assist settings. If
Yeah,
they want to
that's
drop
the
me a line.
person who I was talking about. I'm quite intrigued about these breath-ins on the cough assist at the end, because I've always said I don't get it. Because Vinny,
Yeah, it's not something I do, but
yes, I think if we're trying to clear a secretions, then why are we putting 2 breaths back in? I could never understand it, but
some people believe in it, and like I said at the beginning, everyone does them slightly differently.
Yeah, exactly. All right then, well, thank you very much for your time, Lisa.
No worries, thanks.
All right, see you later.
Bye.
Mate. Yeah, bye, mate. Bye.